Welcome back to the deep dive. So, today we're going to start with a scenario that I think is going to feel pretty uncomfortably familiar to a lot of you listening. You're standing there in front of the bathroom mirror, maybe you're, I don't know, 35, maybe 45, and you're getting ready for a huge presentation or a parent-teacher night, and you look.
Mm.
You look closely at your jawline.
And yep, there it is.
There it is.
Yeah.
That deep, painful underground cyst just starting to form. And the immediate thought is usually, wait, I did my time. I left this behind in high school. Why am I dealing with wrinkles and acne at the same time?
It feels like a biological prank, doesn't it? It just feels so unfair. And usually that internal monologue starts blaming all the wrong things. You think, oh, I must not be washing my face enough, or I shouldn't have had that chocolate, or I just need to scrub harder.
Right. We go straight back to the advice we got when we were 15.
Yeah.
But looking at the stack of research we have for today, and we're pulling from clinical dermatology guidelines, NHS data, all of it, that advice is actually the exact opposite of what you need.
It is. If there's one thing we need to get straight right now, before we even get into the science, it's this. Adult female acne is not a hygiene problem. You cannot scrub it away. It's a complex, internal biological signal.
And that's really the core of this deep dive. We're going to decode that signal. We're going to look at the why, from the menstrual cycle to stress hormones. We'll break down specific conditions like PCOS and the so-called second puberty of perimenopause.
And then, and this is the important part, we are going to lay out the actual treatment roadmap from what you can get at the pharmacy all the way to a prescription.
Yeah. And we should probably start by just validating how incredibly common this is. Because when you're the one trying to cover a spot with concealer before a big meeting, it can feel like you're the only person on earth dealing with it.
You really do, but the numbers tell such a different story.
They really do. One study we looked at showed over 50% of women in their 20s are still struggling with acne. But the stat that really got me was the older group.
The women in their 40s.
Exactly, 26%. That is more than a quarter of women in their 40s.
And medicine is finally catching up. For so long, dermatology just treated acne as this temporary teenage thing. But now, the guidelines specifically classify it as a chronic inflammatory disease, and that key word is chronic.
It's not just a bad week, it's an ongoing condition.
Exactly.
Okay, so let's get into the engine room. If I'm, say, a 35-year-old woman with a breakout, what is actually happening in my skin? How is it different from a teenage boy's?
Okay, so to get that, we have to look at something called the pilosebaceous unit.
Which sounds incredibly technical, but it's really just the hair follicle and the oil gland attached to it, right?
That's it. It's the little engine in your pore. Now, in adult female acne, you have this perfect storm of three things happening. First, you get excess sebum, or oil production. Second, and this is key, you get something called hyperkeratinization.
Okay, let's break that down.
So normally, the skin cells lining your pore they die and they shed away. You never see them. But in acne-prone skin, those cells get sticky. They don't shed properly. They just clump together with all that oil and form a plug.
So you've essentially corked the bottle.
They've corked the bottle. And that creates this oxygen-free environment, which is the perfect home for player number 3, Cutibacterium acnes bacteria. Now, this bacteria lives on everyone's skin. It's normally harmless.
But when you trap it
in an oily, airless pore, it just goes wild. It multiplies, and that triggers your immune system. The immune system sends in troops, and that battle is what causes the inflammation. The redness, the swelling, the pain.
Okay, so we have the mechanism,
Oil.
plus sticky cells, plus bacteria. But the big question for anyone listening is, why now? What's the trigger?
And that brings us to the real drivers, specifically the androgens.
The so-called male hormones like testosterone.
Correct, though women absolutely need them. But here's where it gets really tricky. You might go to your doctor, get a blood test, and they'll tell you, your hormone levels are perfectly normal. But you're still getting terrible acne.
This is such a huge point of frustration for people. How can the blood test be normal if my skin is freaking out?
Because it's not always about the amount of hormone in your blood. It's about how sensitive your skin's receptors are to those hormones. It's called peripheral androgen sensitivity. Your oil glands might just be sort of genetically programmed to overreact.
So they see a totally normal amount of testosterone and just scream, okay, red alert, full production.
Precisely. Your friend could have the exact same level and clear skin, but your receptors are just dialing it up to 11. And this is often why we see those very predictable cyclical flares. In fact, I'd ask you listening, have you noticed your skin flares at certain points in your cycle?
The classic premenstrual breakout.
Exactly. It almost always happens in the luteal phase, so the week or so before your period. And what's happening biologically is a changing of the guard. In the first half of your cycle, estrogen is dominant. Estrogen is great for skin. It kind of suppresses oil.
It's protective.
It's very protective. But in that luteal phase, estrogen just drops off a cliff.
So the shield goes down.
The shield goes down. And all of a sudden, those androgens, even though their number hasn't changed, they're unopposed. There's no estrogen to keep them in check. So they hit those sensitive receptors, oil production spikes, and a few days later, you've got a breakout.
And then on top of that, you have to layer on stress. I feel like everyone knows stress causes acne, but is it just because we're like touching our faces more? Or is there real chemistry there?
Oh, it is deeply chemical. There's a whole field of study for this, psychoneuroendocrinology.
Wow, that's a mouthful.
It is, but it basically just maps the link between your brain and your hormones. When you're stressed, your body releases cortisol. We all know that. But that stress response also fires up the HPA axis. And when that alarm bell rings, your adrenal glands don't just pump out cortisol, they also pump out weak androgens.
So stress is literally manufacturing acne-causing hormones.
It is. And some research suggests that women have a higher cortisol reactivity in these situations. So you get stressed, your body makes androgens, your oil glands flare up, you get a breakout. And then, of course, looking at the breakout stresses you out.
And you're in the feedback loop.
It's a truly vicious cycle.
I want to pivot now to a specific group of listeners, because sometimes it's more than just the monthly cycle or stress. We ask the question, are you also experiencing irregular periods or other hormonal symptoms? If that's a yes, then we have to talk about PCOS.
Polycystic ovary syndrome. It affects a huge number of women, something like 5 to 10%, but it's so often missed or diagnosed really late.
There's this huge myth that you have to have cysts on your ovaries to have it.
Which is just not true, and it causes so much confusion. The diagnosis is actually based on something called the Rotterdam criteria, and you only need 2 out of 3 things to be diagnosed.
Oh, me too.
Just 2. Number 1, irregular or absent periods. Number 2, signs of high androgens. That can be a blood test, or it can just be the clinical signs like acne or excess hair growth. And number 3, polycystic ovaries on an ultrasound.
So just to be crystal clear, you can have the acne and the irregular periods, have a totally normal-looking ovary scan, and you still have PCOS.
100%, yes.
Is there a specific look to PCOS acne? How would I tell it apart from other hormonal acne?
It tends to be more aggressive, more inflammatory. We're talking about those deep, tender nodules, not just little whiteheads. And the location is key. It really favors the jawline, the chin, the upper neck, the classic beard distribution.
And it's often really resistant to regular creams, right? Why is that?
Because the driver is metabolic. A massive component of PCOS is insulin resistance.
This was the part of the research I found so interesting, that connection between your skin and your blood shear. How does insulin cause a pimple?
It's a domino effect. If your body is resistant to insulin, it has to pump out tons of it to get the job done. And high levels of insulin do 2 really bad things for your skin. First, insulin directly tells the ovaries to make more testosterone.
Okay, so it just turns up the volume on androgen production.
Exactly. But second, and this is a really sneaky part, insulin lowers a protein in your blood called SHBG.
Sex hormone binding globulin.
Right. And you can think of SHBG as like a bus that drives through your bloodstream. Its job is to pick up testosterone and keep it inactive. But if you have a high insulin, your liver makes fewer buses.
So you have all this free testosterone just roaming the streets, causing trouble.
That's the perfect analogy. It's the free testosterone that hits the skin receptors and causes the problem. And this is why for PCOS, lifestyle changes that lower insulin, like a low glycemic diet, can make such a huge difference to the skin. You're basically ordering more buses.
That makes so much sense. Okay, let's move along the timeline. We've talked about the monthly cycle. We've talked about PCOS. What about for listeners in their late 40s, early 50s, the second puberty?
Perimenopause and menopause. This one catches so many women completely by surprise.
It's the ultimate irony, right? Needing anti-aging cream and acne cream at the very same time.
It really is. And it's caused by the estrogen deficiency skin axis. It's a similar idea to the pre-period breakout, but it's long-term. As you head towards menopause, your estrogen levels start to fall, and they fall much faster than your androgen levels do.
So that ratio gets thrown off again.
The ratio is everything. You become relatively androgen dominant. Not because you have more testosterone, but because you've lost that estrogen buffer that was keeping it in check. But, and this is so important, your skin is not the same as it was when you were 16.
Right. It's aging, It's thinner, it's drier.
It's thinner, it produces less collagen, it holds less moisture. So if you take a 50-year-old woman and you throw those same harsh, drying teenage acne products at her,
You're just going to completely destroy her skin barrier.
you will incinerate it. You'll end up with red, flaky, irritated skin that still has acne. You have to be so much gentler.
What about HRT? Hormone replacement therapy. Does it help with the skin?
It can, but there's a huge potential trap here. HRT is generally great for skin hydration and collagen. However, the type of progestogen in your HRT really matters. Some of the older synthetic ones are actually a bit androgenic.
So they can mimic testosterone. You could go on HRT and accidentally make your acne worse.
You absolutely could. If you're acne prone, you have to have a specific conversation with your doctor about finding a skin-friendly HRT, which usually means things like bioidentical progesterone.
Okay, so we've diagnosed the problem from all these different angles. Now people want the solution. What's in the toolkit?
We do have a great toolkit, but I have to start with a disclaimer every dermatologist gives, the timeline.
Ah, yes. The dreaded 3 to 6 month rule.
It is so painful to hear when you just want the spot gone for a date on Friday, but skin cycles are slow. You have to give any new treatment at least 12 weeks to really know if it's working.
Patience is key. Okay, let's start with the stuff you put on your face. Topicals.
The first line is almost always retinoids. Things like adapalene or tretinoin,
The vitamin A derivatives. How do they work?
they go right after that hyperkeratization, the sticky cells.
Yeah.
They speed up cell turnover so the pore lining doesn't get clogged in the first place. They basically prevent the traffic jam from even starting.
But there are some big warnings with those.
Yes. First, you absolutely cannot use them if you are pregnant or trying to conceive. And second, there's the retinoid uglies. Your skin can get really dry and flaky before it gets better. You have to start slow, maybe just twice a week, and moisturize like crazy.
Then you've got things like benzoyl peroxide.
Good for killing the bacteria, but it can be really drying for adult skin.
And a practical tip for me, it bleaches everything. Your towels, your pillowcases. Be careful.
So true. A good alternative for adult women is azelaic acid. It kills bacteria and unclogs pores, but it's also anti-inflammatory, and it helps with the dark marks that acne leaves behind. It's much better tolerated.
Okay, moving up the ladder. When does a doctor bring in the oral medications?
Usually, if the acne is more widespread like on your back and chest, or if topicals just aren't cutting it after that 3-month window, the first step is often an oral antibiotic like limecycline.
But the advice on antibiotics has really changed, hasn't it?
Drastically. We used to have people on them for years. Now, because of antibiotic resistance, the guidelines are very strict, 3 to 6 months max. And we now know they work mainly as anti-inflammatories, not just by killing bacteria.
So they're a bridge to get things under control, not a permanent solution.
Exactly. You always need an exit strategy.
And what about the hormonal route, like the pill?
The combined oral contraceptive can be fantastic. It works by boosting that SHBG bus we talked about, mopping up all the free testosterone. But again, you have to choose the right one. The mini pill, which is progestin only, can sometimes make acne worse.
That's a huge pitfall. Okay, now let's talk about the big gun for hormonal acne that came up again and again in the research, spironolactone.
Spironolactone is a dermatologist's favorite for adult women. It's actually a blood pressure medication, a diuretic, but it has this amazing side effect. It's an androgen blocker.
So it basically puts earmuffs on the oil glands.
That's a great way to put it. The testosterone is still floating around, but the receptor on the oil gland can't hear its message to produce oil. It treats the root cause at the skin level.
That sounds like a game changer for women who have those normal blood tests but super sensitive skin.
It really often is. It takes time to work. You will pee more, and you need your potassium levels checked. But for that stubborn jawline acne, it can be life-changing.
And is there a topical version of that?
Yes, there's a newer cream called clascoterone, or Winlevi. It does the same thing, blocks the androgen receptors right on the skin. It's a great option if you want to avoid taking a pill.
And finally, the nuclear option, isotretinoin or roaccutane.
Yeah, this is the closest thing we have to a cure. It actually shrinks the oil glands permanently. The chance of the acne coming back after a full course is very, very low.
But the safety profile is intense.
It is serious medication. It causes severe birth defects, so you have to be on a strict pregnancy prevention program. It dries out your whole body, lips, eyes, everything. It requires monthly blood tests. It's a major commitment.
It sounds scary, but the sources also pointed out the other side of that, the mental health trade-off. That brings us to the emotional side of all this.
We have to talk about this. We asked earlier, have you been told your acne is just cosmetic? But the research shows the impact is so much deeper than that.
It's profound, actually.
The psychological distress from adult acne is statistically comparable to other chronic conditions like asthma or diabetes. It causes real, measurable anxiety, depression, and social avoidance.
And then there's that pick stress cycle.
Skin picking or excoriation, it's a huge part of the anxiety. You feel a bump, you get anxious, you pick at it to try and fix it, which only makes it worse. Then it scars, which makes you more anxious.
It's so hard to break that cycle.
It is, and that's why the guidelines now explicitly say that you should get help based on the impact on your life, not just the number of spots you have. If it's affecting your mental health, that is a valid medical reason to see a specialist.
That is such an important message. Before we wrap up, a quick word on lifestyle. We focus a lot on medicine, but is there anything we can do at home?
Yeah, biology is definitely the main driver, but lifestyle can help. The low glycemic diet we mentioned for insulin control, that can really help reduce those androgen spikes.
And skincare itself.
Keep it simple. Use what are called syndic cleansers. It stands for synthetic detergent. It sounds harsh, but it's actually much gentler. Soap is alkaline and strips the skin. Sindens are pH neutral. Basically, think of the most boring, bland cleanser you can find. When you're using powerful medical treatments, your cleanser's job is to be boring.
Bland is good. I like that. So we've really built a whole map here, from the pilospecious unit all the way to the Rotterdam criteria and HRT.
We have covered a lot of ground.
If someone listening takes just one thing away from this entire deep dive, what should it be?
I would say stop fighting with your skin and start listening to it.
What do you mean by that?
We spend so much energy trying to scrub and scour and cover up the problem. But your skin is a messenger. It's an external display of what's happening in your internal environment. So if you're breaking out, ask the question, what is my skin trying to tell me? Is it stress? Is it my cycle? Is it insulin?
Just data.
It's just data.
Right.
And once you treat it like a medical signal instead of a personal failure, you can find the right treatment that actually matches the cause.
And you don't have to figure it out alone.
Absolutely not. Use your doctors. That is what they're there for.
Thank you so much for breaking all of this down. It really makes the reflection in the mirror feel a lot less mysterious and a lot more manageable.
My pleasure.
And to you listening, thanks for diving deep with us. Hopefully you're walking away with a plan. Stay curious, and we will catch you on the next one.